Okay, so this is going to be a quick talk on sodium imbalance. This is can kind of be complicated because nephrologists like to make this complicated, but really, if you look at this in a few quick steps, you can usually come to your diagnosis or a suspected diagnosis pretty quickly, and that's good enough for the USMLE. So, symptoms of sodium imbalance. Basically, the way to think about it is that you're going to have the same neurologic symptoms regardless of whether you have hypernatremia or hyponatremia. So anything from weakness to forgetfulness all the way up to seizures and coma. You can run the whole line. So the important labs you're going to want to have here, and usually they'll just be given to you on the exam because you can't really get a question on sodium imbalance unless they tell you that you have a sodium imbalance. Usually they're going to want you to find the cause. So you want to have your CMP for your plasma osmolality and your plasma sodium, and you're going to want to have a urine on this patient, mostly for the urine sodium. I don't really bother with urine osmolality, and I'll show you why. Usually if you just have your urine sodium and your plasma osmolality and of course your plasma sodium, that's usually good enough. Some math to know how to calculate the plasma osmolality. It's 2 times the sodium plus the blood urine nitrogen over 2.8 plus glucose over 18. This is not given to you on the USMLE, so you need to commit this to memory. Alright, so let's say we've got a patient with a sodium less than 135. The first thing we need to think of is, this is how you do it on the USMLE. In real life, the first thing you're going to think of is what's the patient's volume status, because you're going to see the patient. But on the USMLE, this isn't the way you think it out because you're looking through the question. And so as you attack this on a USMLE question stem, this is how you're going to want to think of it to make this easy on yourself. So we have a patient with hyponatremia. We have to ask ourselves, does this patient also have hypotonic plasma? And the reason that's important is, well, look at how big of a role sodium plays in the plasma osmolality. If this patient has hyponatremia, then they should have a hypotonic plasma. Look how big a role sodium plays in the osmolality. If the patient has a plasma that's not hypotonic, if it's normal or hypertonic, then one of these other factors has to be the cause. And generally it's glucose. We have a very high glucose level, and so we're pulling in fluid, and so that's going to cause the plasma osmolality to be higher than it's going to cause the hyponatremia to be false. Let me rephrase that. It's going to cause the sodium to look low when it's actually not. And so don't really worry about the cause. Just know that if you have a greater than 280 or a non-hypotonic plasma in the setting of hyponatremia, that it's pseudo-hyponatremia. And it's just glucose pulling water out of the cells. Is the best way to think about it. Okay, so we know that we have a hypotonic plasma patient with hyponatremia. Next thing we do, we look at their volume status. Obviously, if the patient has a blood pressure of 80/50, and even if their sodium is 133, we're not going to correct their sodium first. We are going to pump them with fluids. So think of your ABCs first in any question, then look at their volume status. Are they hypovolemic? Do they have sunken eyes? Decreased capillary refill? Are they euvolemic? Are they just fine? Are they hypervolemic? Do they have edema? Those are the things you want to think of. So if you're hyponatremic, there's 2 ways you can become hyponatremic. You can either lose too much sodium or you can retain too much water. If you're losing too much sodium, you're going to be hypovolemic. And the simple reason is because if you're retaining too much water, you're hypovolemic. Okay, that makes perfect sense because if you have edema and you have too much water in your body, either third spacing it or whatnot, you're hypervolemic. If you're not retaining water, you're hypovolemic. And so the only other way you can become hyponatremic is that you're losing sodium. And so what are the ways you can lose sodium? Well, you can lose sodium through your kidneys or not through your kidneys. So if you're losing sodium through your kidneys, where are we going to see the sodium? Well, we're going to see the sodium in the urine. And so what you look at is your urine sodium. In any case, hypovolemic, euvolemic, hypervolemic, if your urine sodium is greater than 20 and you're hyponatremic, it's a renal cause. Always, 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 always. You should never pee out more than 20 milliequivalents of sodium in your urine if you have hyponatremia. So if your urine sodium is greater than 20 and you have hypovolemia, the thing to think about is interstitial renal disease, tubular interstitial renal disease. And the simple cause of that is because your tubules aren't functioning. Your glomerulus is working fine, you're getting your filtrate all the way through here, but your tubules aren't working. And so you're not reabsorbing sodium and chlorine. And with that, you're not reabsorbing water. So that's what's going to cause the hypovolemic hyponatremia. If your urine sodium is less than 10, but you're still losing sodium, so it's not coming out of the urine, then we think of other places. Where else do we lose sodium? Well, we can lose it through the bowels. We can lose it in diarrhea. We can lose it in vomiting. We can also lose it through the skin. We can lose it in sweat. We can lose it through burns. We can lose it in adrenal insufficiency. And adrenal insufficiency is kind of one of those that can fit either. Because if you think about it, what is adrenal insufficiency? It's a lack of aldosterone, and aldosterone kind of works on the kidneys, so it sort of falls under both. So think of that as fitting under either. And then cerebral salt wasting, I wouldn't worry too much about that. That's more rare. We'll talk about that more when we talk about neurologic conditions. So how do we tease out adrenal insufficiency from the hypovolemic cases? Well, what does aldosterone do? It causes us to reabsorb sodium at the expense of potassium. So what we're going to have in adrenal insufficiency is low sodium and high potassium, because we don't have the thing that causes us to absorb sodium and get rid of potassium. So we're going to have a high potassium and a low sodium. So what you'll see here is an extra-renal sodium loss, so a low urine sodium, with hypovolemia, with hyponatremia, and a high potassium. So the high potassium is what's going to distinguish this adrenal insufficiency out from the rest of the extra-renal causes. And you can think of the GI loss. What are you going to have if you're vomiting? You're going to have your hyponatremic, hypokalemic metabolic alkalosis, because you're losing potassium, you're losing hydrochloric acid in your stomach. So that's another way to tease out GI loss. But usually you'll have that in your history. So those are the hypovolemic causes of hyponatremia. Hypervolemic causes, well, what happens here? Well, we're obviously not losing sodium. We have to be retaining too much water because we're hypervolemic. Hypervolemia means we have too much water. So if we have low sodium, just like in hypovolemia, if we have low sodium and yet we're peeing sodium out, it's a renal cause. And the thing to think of in a hypervolemic hyponatremia is end-stage renal disease, if we have too high of a urine sodium. So why do we think of end-stage renal disease and not interstitial renal or tubular interstitial renal disease? We think of end-stage renal disease in the hypervolemic hyponatremia because the failure is the entire kidney. It's not just the tubules. What happens here is this whole process doesn't even happen. So we're not getting any urine. Patients with tubular interstitial renal disease, they have urine. So they're getting rid of water. That's why they're hypovolemic. Patients with end-stage renal disease, they're anuric. They're peeing out less than 100 milliliters of urine per day. So not only are they not filtering out sodium, they're not even filtering out water. So they're hypervolemic because they're not filtering out water. They've got too much water in their bloodstream. And they're not filtering out sodium, but that doesn't matter because they've got a ton of water sitting in their bloodstream. So that's what makes them hypervolemic and hyponatremic. If their urine sodium is low, again, that's the way it should be because they're hyponatremic, but in this case we don't have a renal cause. And so it could be congestive heart failure. Well, why does congestive heart failure cause us to be edematous? Well, it causes us to be edematous because we are going to increase our aldosterone. It's the renin-angiotensin-aldosterone system. Congestive heart failure means you're not getting blood up to your brain. If you're not getting blood up to your brain, you need to increase your volume. And so by increasing your volume, you're going to cause a hyponatremia because you're diluting out your plasma. So congestive heart failure is a cause of a hypervolemic hyponatremia. Cirrhosis, it's pretty much the same thing. You're having the blockage in your liver, though. Nephrotic syndrome is kind of a renal cause, but what you're getting here basically is fluid leaving your bloodstream, going into third spacing, so you're going to get that edema, and then the blood pressure is going to drop because of that, and so then you get the renin-angiotensin-aldosterone system kicking in because the kidneys are sensing, oh, I'm not getting enough perfusion, so I'm going to kick in the renin-angiotensin-aldosterone system, and so you're going to absorb more water. And so what happens then is you get a hyponatremia because it's going to dilute the sodium in your plasma. So anything that causes edema would fit under your low urinary sodium, hypervolemic, hyponatremia. So let's say that the patient has, they're not hypovolemic or hypervolemic, they're euvolemic. Well, then in this case, what we can think of is SIADH. So in this case, SIADH, which has multiple causes, what you're getting is too much ADH, too much antidiuretic hormone, which remember works here. And antidiuretic hormone allows us to reabsorb water. And so if you're reabsorbing too much water, you're going to dilute your plasma, and that's going to cause a hyponatremia. Endocrinopathy, that falls under adrenal insufficiency and hypothyroidism. Remember what I said, adrenal insufficiency can kind of fall under any of these, so you have to tease this out, and what you just do is look at your potassium. If you have a high potassium and a low sodium, hyperkalemia along with hyponatremia in the same patient, a lot of times is adrenal insufficiency. So that's kind of your hint for that. Hypothyroidism, I have no idea why that causes it, but just remember that is an actual common cause of hyponatremia in a euvolemic patient. And then the usage of diuretics. You'll just have to look at the history for that. So, kind of a recap, the rudimentals of finding the cause of hyponatremia. When you have a patient with a sodium less than 135, apart from making sure that it's not pseudo-hyponatremia, that it's their plasma osmolality is below 280, you want to assess their volume status and their urine sodium. If their urine sodium is high, it's a renal cause. If their renal sodium is low, it's an extra-renal cause. Of course, if the patient's volume depleted, you're going to want to bolus them up with normal saline. And then, like I said, high urine sodium is renal. Low urine sodium means it's extra-renal or nephrotic syndrome. If you have a patient with no renal disease, no congestive heart failure, no cirrhosis, no edema, they don't have blue thumbs, they have no apparent loss of body water, no history of vomiting, diarrhea, etc., 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 but they do have a low sodium, especially if they're euvolemic, then you start thinking of SIADH, which is kind of your diagnosis of exclusion. So what is SIADH? It's caused by too much ADH secretion. ADH is that hormone that increases your aquaporins, and your aquaporins are right here. ADH increases the amount of water reabsorption, and so if you increase your water reabsorption, you're going to dilute your plasma, and it's going to dilute out the sodium, so you'll have a low sodium. Usually this presents as a euvolemic patient, and the causes are multiple. So you're going to really have to look into the history and do some investigating in these patients. It can be infections, it can be tumors, especially at the lung, antidepressants, especially the SSRIs, some antipsychotics, but most particularly haloperidol, mood stabilizers such as Tegretol or carbamazepine, and then chemotherapeutics, especially the vinca alkaloids. You're going to treat these patients just as you would any other hyponatremic patients. Hyponatremia is hyponatremia, but in this case you can add dimethylcycline or lithium because they actually do inhibit ADH. So how do we treat the hyponatremic patient? Well, first off, if you suspect volume depletion, you have to remember your ABCs, and you've got to bolus this patient with normal saline or Ringer's lactate. Once you've done that, then if you can manage the underlying cause, if you know what it is already, do that, assuming that they don't have any severe symptoms. If they have no symptoms at all, and this is just an incidental finding, and they're in for something else, then just restrict their fluid until their sodium comes back to normal. If they have mild symptoms, so more of the fatigue, lethargy, etc., you can just administer 1/2 normal saline at your maintenance rate and then monitor their sodium levels every 2 hours or so. You can add furosemide. Why add furosemide? Because furosemide actually causes more urination of water than it does of sodium. And so furosemide is a good one to actually increase your sodium because you're actually going to lose volume. So furosemide can be okay, but not really so much in the hypovolemic patient. This is more for the hypervolemic hyponatremic patient. But definitely 1/2 normal saline at maintenance rate. Don't increase your sodium by more than 1 milliequivalent per hour. That's why we check every 2 hours. If the patient has seizures or coma or even altered mental status, I would say, you can administer 100 milliliters of 3% hypertonic saline at 1 milliliter per kilogram of body weight per hour, and of course monitor your sodium levels every 2 hours. This is a medical emergency, so we can take more liberties in these patients because the seizures and coma do put these patients at risk for death. But we don't ever want to increase the sodium any more than 2 milliequivalents per hour, even in these patients. And why? Because you do not want to give your patient central pontine myelinolysis. I tried to find an MRI where it didn't have this arrow, but you can see here that this is the problem right here. And so this is the lesion, and if you don't want to give your patient locked-in syndrome, which would basically be like hell on earth, because the only thing you'd be able to do is blink, but you'd be conscious forever, don't correct your patient's sodium too fast. Alright, so moving on, if the patient's hypernatremic, this is going to be a lot easier. So basically, if the patient's hypernatremic, we just have to look at the patient's volume status. The most common cause of hypernatremia is an inadequate fluid intake. So let's think of what can cause hypernatremia. So you have too much sodium in your serum. Too high of a concentration of sodium in your serum. So how does that happen? You're either losing water, or you're not getting enough water, or you're getting too much sodium. So you're either not getting enough water, or you're taking too much sodium, or you're losing too much water. So if you're losing too much water, you're not getting enough water, well, you're going to be hypovolemic because you're not getting enough water. So number one cause by far is inadequate fluid intake. And these are going to be your patients. Usually, I mean, you're not going to dehydrate yourself. These are the patients that come in and they're brought in by emergency because they're an elderly person who may have dementia and they live in a nursing home, or they live at home by themselves and they're not hydrating themselves and they have a sodium of 153 and they're obtunded. Inadequate fluid intake, number one cause of hypernatremia. Excessive urinary loss, these are going to be the kids that come in and they've got, they're also obtunded, and they have a sodium of 148, but they also happen to have a glucose of 1000. And these are kids that are now suddenly diagnosed with diabetes. They didn't know it before because they weren't taking their insulin. Or maybe they were diagnosed with diabetes, but they just chose not to take their insulin. That's diabetic ketoacidosis. So another hypovolemic hypernatremia. And why are they losing urine with the DKA? Well, they're losing urine because they have glucose coming out of in their urine, and that's drawing out water. And so they're being dehydrated because they are just spilling glucose out like crazy. And then extreme diarrhea. That's more like the patients that have severe cholera. We're not going to see this in the U.S. that often. Hypervolemic hypernatremia. If you ever see that, you better get your lawyers on the line because that's probably your fault. This is usually when you've been giving the patient too much normal saline, too fast, you bolus them a couple times too much when you shouldn't have, or you've been running their D5 half normal saline or their normal saline, depending on whatever you're giving them, too quickly. So that's generally iatrogenic. You're probably not going to see that on the USMLE, but know that it does happen. Euvolemic hypernatremia, the big one to think about is diabetes insipidus. So what is diabetes insipidus? It is the exact opposite of SIADH. So diabetes insipidus is diabetes because diabetes just means too much urine. You're urinating a ton. And it's diabetes insipidus because it is not due to sugar. So diabetes insipidus is due to either ADH, not having enough ADH, or the ADH that you do have isn't working. And you want to figure out what it is because that's going to affect our treatment. So when you have a patient that is euvolemic and hypernatremia, and you'll usually know this because these are the patients that come in and they say, I am peeing 15 times a day and I am not drinking water that much. And you can distinguish it from psychogenic polydipsia because these people with diabetes insipidus will either get up to use the bathroom at night or they'll just wet the bed. So if they have diabetes insipidus, if that's your diagnosis or your presumptive diagnosis, what should you do? Well, either they don't have enough ADH or the ADH is not working where it should be in their kidneys. So all you have to do is give them a trial of ADH, of vasopressin. And what happens is if their urine volume decreases, if all of a sudden they stop peeing every half an hour, then it is considered central diabetes insipidus. Why central? Because it's from the brain. And you make ADH in your brain. And so what's happened in these patients is that they just don't have any ADH anymore. And so because you've replaced the ADH, everything's fine. And so the way we treat those patients is we just give them ADH as usually I think they do that now as a nasal mist. So those patients are treated quite easily. If they don't have any change, then what's the problem? Well, it's not that they don't have ADH, it's that the ADH is actually not working on their kidneys. And so what we do for these patients is we give them NSAIDs and we give them hydrochlorothiazide, which will actually help with the hypernatremia because hydrochlorothiazide will cause us to lose more sodium than we do water. So these patients are still going to have to drink a lot of water because they're going to be losing water, but what you give them is NSAIDs and then hydrochlorothiazide to try to keep their sodium up, or try to keep their sodium down, rather. So in general, to treat any patient with hypernatremia, we're going to want to treat the underlying cause, and that's usually pretty easy to do because there's not many causes of hypernatremia: inadequate fluid intake, excessive loss, either due to DKA or diabetes insipidus, extreme diarrhea, or iatrogenic. So you can usually narrow it down to one of these 5. So treat the underlying cause. Obviously, these patients should be drinking water if they can. And then you want to replete their IV volume. If they're hypovolemic, definitely you've got to replete their volume. And how are you going to replete that? You're going to replete that with normal saline. You don't ever give somebody a bolus of D5 half normal saline. You don't ever do it. Okay, so when it's an emergency and their blood pressure is 90/60 or they have decreased skin turgor, even if they're hypernatremic, you still give them normal saline, even though there's something else that you might give them later on down the road that has less sodium concentration in it. You still want to give them normal saline to revive them, so to speak, to replace their sodium balance, their water balance, rather. Once you've done that, then you can use half normal saline all you want and replenish their volume. And then you're using, obviously with half normal saline, you're using a hypotonic solution. You actually want to avoid using glucose-containing fluids in patients with hypernatremia. And to be dead honest, I really don't even know why that is. That's just something that we do at any hospital, and it's kind of a principle. And I'm not sure the USMLE will test you on that, but if they do, it's a good thing to keep in mind. If anything, it's just good to keep in mind for the wards. I think there's some kind of neurologic issue with that. So management of any patient with hypernatremia, first is to, if you suspect volume depletion, is to bolus them up with normal saline, not half normal saline. Even though they're hypernatremic, we want to still give them 0.9% or normal saline, or you can use Ringer's lactate if that's what you want to do. Really, it doesn't matter. Manage the underlying cause. Work them up for diabetes insipidus if that's what you're thinking. If they're euvolemic and they don't have a glucose of 1,000, if they're not an old person who hasn't been able to get to water, they don't have extreme diarrhea, or they haven't been in the hospital for a doctor to make them sick. And then administer half normal saline at your maintenance rate and monitor their sodium level every 2 hours. Do not decrease your sodium faster than 1 milliequivalent per hour. And that's important for the same reason. I don't think it causes central pontine myelinolysis, but just don't correct their sodium too fast. You can cause bigger problems. And that's all I've got for you for disorders of sodium imbalance.